Hello. Welcome to the CME certified activity entitled Autologous Hematopoietic Stem Cell Transplantation and Mobilization in Multiple Myeloma, Current Debate and Developments. This is part 2. I am Dr. Parmeshwaran Hari, Professor of Hematology at the Medical College of Wisconsin, and with me, Dr. Nina Shah, Associate Professor of Medicine at the University of California, San Francisco. Today, in this second part, we'll be discussing the most recent clinical data on autologous hematopoietic stem cell transplantation and also induction maintenance treatments in multiple myeloma and provide evidence-based updates and expert insights on this topic. Here are our disclaimers and disclosures. So we talked about the transplant paradigm and how we use transplant, and as we discussed a little bit in part 1, maintenance seems to be an important component to extend the benefits of transplant much more than we've been able to do in the past.
Right.
And here is this meta-analysis, which is probably the most powerful evidence we have, because it collates all the 3 trials that have been done in this setting.
Yeah, I think this was first presented at ASCO in 2016, and I was really floored by both the analysis and the ultimate results that it showed, because it's hard to put a lot of trials together. But basically, this takes 3 randomized trials that had been conducted and collapses the data so that we can all understand it easier. And the critical thing about this meta-analysis is it looks at trials looking at lenalidomide maintenance, those people that got it or didn't, and also it's in the era of novel therapeutics. And as you can see on the next slide, when they did this meta-analysis, they were able to show that there was an actual increase in overall survival, which you can see on the curves. So they were able to show that patients who got lenalidomide maintenance, as they were randomized to get, actually were able to have longer survival. And what's really nice about these curves is you can see that top one stretching out where almost the median is just being hit so far out, 10 years out.
Right, 62%. 7 years later are still, which is an amazing number.
So,
which was not even thought possible when these studies were actually started.
Right. No one knew it was going to be this way. So that's really sealed, I think, the fate of maintenance. And I think further what's sealed it is updated results or new results from the BMT-CTN0702 trial. You want to talk about the design of that?
Yeah, actually this is a very important study, one of the largest transplant studies in the US. And it was for 750 plus patients with newly diagnosed multiple myeloma, age less than 70. And the question really was being asked was, now we have transplant followed by lenalidomide maintenance as the paradigm. Can we improve upon that with additional therapy? So that's the question. And we already know that transplant with lenalidomide maintenance is the standard, and it improves overall survival to almost to the first decade of life after myeloma. So here, after a transplant, patients could follow 3 paths. Lenalidomide maintenance would be the standard path. Initially, when the trial was written, it was written for 3 years of maintenance, but now patients have the option of staying on it till progression. And then a second arm was consolidation with the RVD regimen, which is bortezomib, lenalidomide, and dexamethasone for 4 cycles, which takes about 12 weeks to complete. Thereafter, patients go on lenalidomide maintenance. And the third arm was a second autologous transplant or tandem transplantation, because we have a lot of data from Europe suggesting that tandem transplantation is better than a single transplantation. So this was a very standard study. And induction therapy, was not mandated to be anything in particular, but the significant chunk of these patients, more than 50% in fact, got RVD, or bortezomib, lenalidomide, dexamethasone as induction therapy, which is a key difference from European studies. So here are the results. And as you can see, there was essentially, the bottom line is you could not beat simple lenalidomide maintenance following transplant with at least these 2 strategies. Tandem transplantation or consolidation before len maintenance after transplant were not able to overcome the advantage we have gained from len maintenance alone. So for the time being, len maintenance remains the standard after an autologous.
And so we kind of wanted to move on to some of the guidelines. A couple of years ago, the ASBMT, or the American Society of Blood and Marrow Transplant, published some practice guidelines that helped us and practitioners around the U.S. to look for guidelines about when to refer for transplant really what the role is of transplant for patients. And we tried to grade our evidence on an A through D, with A being the best. And we tried to use studies that had looked at randomized controlled trials and maybe outcomes with survival for grade A evidence. And based on that, we've been able to make multiple recommendations. The first is whether or not to use transplant. And so we do, as a grade A recommendation, based on the studies we've talked about at length in the first part, recommend consolidation upfront autologous transplant after induction therapy, whatever the choice is. Exactly, and that's a grade A. And interestingly enough, a lot of the other opinions surrounding transplant are not due to randomized control trials, because they're hard to do, but a lot of retrospective studies and actually expert opinions. So we also thought that although the evidence isn't as strong, that you should consider a transplant even if you have relapse or refractory disease. It's still an option, and that age should not be considered a selection factor. And for high-risk patients, which we haven't talked about too much, that you should always consider clinical trials, because we don't know how these patients do the best, although we think transplant's part of it. We also talked about melphalan 200 being the standard of care, and we'll talk about some novel formulations of it.
And here again are some of the other recommendations for further therapy. As you saw, post-transplant consolidation with either a second transplant or other agents such as RVD are not recommended. And especially we have confirmation with that from the STAMINA study. And immunomodulatory drug lenalidomide is the standard of care maintenance.
And FDA approved now.
And FDA approved now in the United States for this. And patients with high-risk disease, such as translocation of 414, 1420, 1416, etc., and or those with kidney failure, post-transplant bortezomib may be considered, and the evidence for that is a little bit less than the evidence for lenalidomide. So here are some other data on the role of a salvage second auto transplant. Here again, there is only one randomized study in that setting, which we haven't touched upon, but was a study from the UK, which suggested that a second transplant was beneficial in people who relapsed more than 18 months after their first auto transplant. And based on that, the ASBMT recommendations recommend that as a safe and efficacious modality for people who had a especially longer remission after their first transplant. And as we said before, if you collect cells for more than one transplant, they're better utilized in a salvage second transplant setting than as a tandem upfront transplant based on the STAMINA study results that we just showed. And the role of maintenance therapy after salvage at this point is unclear.
We don't know, and hopefully we'll have clinical trials to answer that, but it's good to consider.
Let's now talk about going back to induction, which is the treatment before transplant, and can we improve it? The big question is, we have shown what is the state of the art right now, but what is coming? And what are the data for improving each component of this paradigm?
How can we get even better?
How can we get better? How do we go to the next level in myeloma? So the big question is, if a transplant is planned, does induction matter? And I don't think we have a clear answer for that, because the studies have generally looked at transplant versus no transplant or things like that. But we have some answers on the question of 3 drugs in induction versus 2 drugs in induction. And if you choose 3 drugs, which are the 3 drugs that are ideal? Is it a proteasome inhibitor, IMiD, and dexamethasone? Or is it an alkylator such as cyclophosphamide with a proteasome inhibitor, or an IMiD with dexamethasone? So, some of the data are here. So this is a SWOG study, and I think you were associated with that.
But this is, I think, one of the most important studies in myeloma, because all of us had really thought combination of the 3 drugs probably would be better, but we really needed to prove that. And I think this really helped us to prove that. So in this trial, patients were randomized to receive either 3 drugs with bortezomib and lenalidomide and dex, or 2 drugs with just lenalidomide and dexamethasone. And this went on for 8 or 6 cycles just to keep the time consistent between the 2. And then they went on to maintenance. So you can see it wasn't with transplant necessarily. And here there was a clear advantage for 3 over 2 drugs, both for the progression-free survival and the overall survival. And for me, this really sealed it that I should, when possible, be recommending 3 drugs to my patients rather than 2.
I think that this study clearly proves that in this day and age, for newly diagnosed myeloma, the combination of a proteasome inhibitor, lenalidomide, and dexamethasone, which is the VRD regimen, is probably the best way to go up front, and whoever that can tolerate that regimen.
Exactly, which is, always have to consider that.
So here is a study from the French myeloma group, or IFM, and they asked a slightly different question. When you choose 3 drugs, which are the 3 drugs? A proteasome inhibitor with an IMiD and dexamethasone, or the RVD combination. In France, they prefer to use thalidomide instead of lenalidomide. So that's a very similar combination called the VTD, which stands for bortezomib, thalidomide, and dexamethasone, versus substituting the thalidomide for cyclophosphamide, which is an alkylator, a cheaper drug, and has some advantage in terms of cost. So the question was 4 cycles of VTD versus 4 cycles of VCD. Here we call it Cybord. And in patients who are eligible for transplant and going to transplant, what sort of responses can be obtained from these 2 different regimens? That was a question.
So you can see here that the response rates, when you look at greater than very good partial response, favored the thalidomide arm, so that would be bortezomib and thalidomide and dexamethasone over the bortezomib cyclophosphamide dexamethasone. And although there was some more neuropathy with the thalidomide containing regimen, it was thought that perhaps the combination of the proteasome inhibitor and the IMiD, or the immunomodulatory drug, and dexamethasone is better for response depth than the proteasome inhibitor and cyclophosphamide or alkylator. And I think that's one of the reasons that a lot of us, even in the States, kind of taking this data and adapting it to our own practices, would choose lenalidomide-based therapy with lenalidomide, bortezomib, dexamethasone.
Again, if you're going for a transplant, there are data suggesting that if you get to a better than VGPR status before transplant, your outcomes post-transplant are better. So we should try to get as many patients into that regimen in as efficacious a manner as possible. And if the combination of IMiD proteasome inhibitor is the combination to go for in that setting, with that objective in mind. So I think we have, most of us feel validated in our approach with using the VRD regimen.
Yes, with good data behind it.
Good data behind it. And here is a study which tries to go to a 2nd generation proteasome inhibitor.
Getting even better.
Improving on induction.
Can we get better?
Can we get better? So here the goal again was not the VGPR status, it was the status of minimal residual disease negativity. So I think we are moving away from a cruder form of response assessment to a more sophisticated form of response assessment too. This was done through the MMRC and the University of Chicago. And these were 2 parallel studies actually done some time apart, so not clearly parallel, but two studies, one of which used the KRD regimen, which is carfilzomib, lenalidomide, dexamethasone, the 2nd generation proteasome inhibitor, with a transplant or without a transplant. And they're very similar. They used KRD induction, transplant, consolidation with KRD, and then KRD maintenance, followed by len maintenance off protocol. So these are the transplant results, and if at 8 cycles, you can see that about 67 and 63% of patients are in a stringent CR or a complete remission, and correspondingly, the number for 8 cycles in the without transplant arm are in the 30%. After 18 cycles, and including a transplant, it goes up to about 85%.
Which is unheard of.
Unheard of. And without transplant, that's still in the 50 to 60% range.
Also unheard of,
which is very good, exactly.
So, which is great.
But again, 2 points. You can achieve these remissions, and transplant makes it better for at least 20% more patients. So if you don't know who these patients are, so that's why you end up offering the transplant to everyone. So in summary, I think we both agree that transplant is key, as we said in the first part of this. Collection and holding early is also another option. Induction matters, and as we have shown, as induction improves, overall outcomes improve, even in the setting of transplant. And lenalidomide maintenance is with significant benefit, despite its risk of venous thromboembolism, cytopenia, which is low blood counts, and also a small increase in the risk of second primary cancers. So the standard at this point is 3-drug induction, ideally using a proteasome inhibitor, immunomodulator, and dexamethasone, or followed by a melphalan-based autologous transplant, and then lenalidomide maintenance.
Which I think a lot of us would agree with, and I'm glad that we've all come together, sort of after years and years of debate, and most of us are doing this, I think.
It is the modern version of total therapy.
Yes, the modern total therapy,
In the next part, we should discuss the often forgotten
but very important
conditioning regimen in transplant. So conditioning regimens have not changed a lot. This was a study done in 2002, which compared, at that time the question was, should we use total body radiation, because myeloma is a very radiosensitive tumor, and with melphalan, or should you just give melphalan alone? And the study was pretty conclusive in that MEL 200 is the standard, and addition of total body radiation with MEL-140 was not up to par. Overall survival was just barely statistically significantly better for MEL-200,
right.
but the toxicities were significantly
right.
higher for
something to consider.
So melphalan 200 became the standard, and that has been the standard now for almost 2 decades.
Yes.
But then melphalan is a very, very old drug,
right.
And we have major issues with melphalan, and there has been renewed interest in making this better, either with addition of new agents to the melphalan, or improving the melphalan itself
right.
to be more potent.
Right.
So here are some of the issues.
So the melphalan that we've traditionally used is actually very unstable. And to make a long story short, it becomes reconstituted and then has to be immediately given. And this is a problem because not every hospital can immediately run from their pharmacy and give the melphalan to the patient. And the most important thing about melphalan is getting it into the patient, because we know it's the density of the drug that makes the difference for these myeloma cells. So it starts to lose its effect even within the first 10 minutes. So we wanted to make sure that we could actually overcome this. And because of this, a new formulation of melphalan has been developed, because we want to make sure that patients are able to get it on time, and that they're able to get the effective nature of the melphalan infused, and that it doesn't just dissolve away and is ineffective.
So to get a predictable concentration of melphalan in the patient and a predictable AUC and Cmax, a new formulation of melphalan was developed which eliminates propylene glycol, which is usually added as an additive traditionally. Melphalan is very difficult to get into solution.
Right.
So they used to mix it with propylene glycol to get it into solution. So the new melphalan is called propylene glycol-free melphalan, or it uses an agent called Captisol to get melphalan solubilized. So it's either called Captisol-enabled melphalan, CE melphalan, or PG-free melphalan, propylene glycol-free melphalan. This was a pharmacokinetic study which compared CE melphalan with regular melphalan at 100 milligram per meter squared dose. And it was shown that just by the use of CE melphalan, without any other optimization, you could get 10% more higher levels of melphalan into the patient. And melphalan being a dose, melphalan has a dose response curve in myeloma.
Right, we know that.
We know that from many studies. For example, MEL-140 is less effective than MEL-200.
Right.
And because of that, we believe that we have a safer product which has a better ability to achieve the dose response effect in myeloma.
And it's more stable.
And it's much more stable, which eliminates a lot of the logistics issues with melphalan administration. Here is the data from a phase 2 study that was performed with the CE melphalan, and which showed that deep responses could be achieved with a more than VGPR response in almost 75% of patients undergoing this using an independent reviewer assessment.
Right, and so it looks like even with independent reviewers, the outcomes were essentially as you would have predicted for regular melphalan, with very good overall response rate, 100%, and a better than VGPR response of 61%, which is great.
Absolutely. So again, we coming back to the modern triple sequence, which is induction, transplant, maintenance. Each component can be improved.
Absolutely.
We talked about 3-drug induction as being the standard now, which may get better with the addition of antibodies. And then agents to use improved transplantation with new combinations, or with agents such as the new melphalan, which is the CE melphalan, or using a immune strategy along with transplant, which we didn't talk much about. And then maintenance, primarily with the lenalidomide and bortezomib in special situation.
So one of the things we wanted to talk about before was the high-risk patients, and just briefly to touch upon this, we have an ongoing trial that looks at allogeneic transplant. So remember I was saying that we don't routinely recommend allogeneic transplant for upfront myeloma, but there's sort of a special group with these high-risk patients. They are harder to treat. We know that their duration of response is less, and once they relapse, it's very hard to catch up with them. So we wanted to see if there's something else besides just chemotherapy we could do for them. And one of the things was an allo transplant, because remember that an allo transplant not only gives chemotherapy, but also allows for an immune-mediated effect because of a donor T cell. And so for patients that have high-risk disease, they're eligible for the ongoing BMT CTN 1302 trial. And this looks at patients who are transplant eligible with high-risk disease and gives them chemotherapy with fludarabine and melphalan, but also with bortezomib, which may be able to help them with their anti-myeloma effect, and then randomizes them to ixazomib versus placebo.
So this is an important study in that the patient population that we are using for the study is very specific. Patients with well-defined high-risk myeloma such as plasma cell leukemia or genetically defined high-risk myeloma either by cytogenetics or gene expression profiling, and importantly, people who do not get the expected benefit from an auto transplant. So people can go on the study if they relapsed too early,
an early relapse.
Early relapse, which is independent of FISH and cytogenetics and whatever you may have thought their risk was up front. When a person relapses too early after a standard auto transplant, it always portends a poor prognosis.
So one of the other things I think is really interesting now is immunotherapy in myeloma, and it would be an entire other session for us to talk about that,
right.
But I wanted to touch upon things that are available for patients now. One of them is this BMT-CTN 1401 trial, and the interesting thing about that is it's using a patient's own myeloma cells to make a vaccine. And so patients that are newly diagnosed with myeloma, we're collecting their tumor and then putting it in the freezer, and after they get their transplant, randomizing them to get vaccine or not vaccine. And those patients that get vaccine will have their tumor fused with their own immune cells as a vaccine and have that injected 3 times during their already planned maintenance therapy with lenalidomide.
Yeah.
And one of the great things about this trial is not only that it's being conducted in multiple centers, which are making their own vaccine, but it's taking advantage of transplant itself, which is a really nice immunologic time to try to put in more immunotherapies. If you can imagine that you're giving this high-dose chemotherapy and patients' immune systems are sort of reset, this is a good time to develop the immune system towards being against their own myeloma, which I think is one of the waves of the future.
I think it's a great trial, and it proves it's a personalized vaccine.
Yeah.
So this is a proof of a personalized study.
Yeah.
Each patient is getting a vaccine that's unique to their myeloma.
It's their myeloma.
Their own cells,
Yeah.
their own immune system. And as you mentioned, a reset immune system after transplant at a time when the disease burden is very low.
Right.
And at a time when the T cells or the immune cells are getting educated about their environment.
The
relearning. And that's the relearning process, you're accelerating it against myeloma. So if this trial works out, it'll be, again, a game changer in myeloma.
I think so too. There was actually a lot of new immunotherapies coming out, and we just want to talk about a few of them. We talked about vaccine, which is now being actually studied in a randomized controlled trial, which is really exciting. But there are really many other immunotherapy options being developed in early phase. For example, chimeric antigen receptor T cells, which use T cells that are directed towards myeloma antigens, and recently there's been exciting data about that. Again, early, but I think something that's coming along down the line. We talked about antibodies. So for example, daratumumab, which has now gotten such great data in the relapse setting, we're trying to see if we can move it up front, and the trials are ongoing to look at that. And then something called checkpoint inhibitors, which are molecules that work to help T cells and NK cells work better. Cells that may have been otherwise exhausted or tired and not able to function well, it sort of wakes them back up. And it's possible that patients with myeloma have a lot of these exhausted immune cells, rejuvenate these cells that could help fight against a patient's own myeloma without having to get another antibody or cell therapy. And then we also have some NK or natural killer cell-based strategies, which look at sort of an immune system cell type that's usually used to treating tumors, or fighting your own tumors, that gets exhausted also. And if we could give new NK cells, maybe that would help fight myeloma better. All of these are so exciting, and we're not sure exactly where to use them yet. Some of them up front, some of them during transplant, but we're really hoping to have more clinical trials to look at that. And so there are a lot of discussion points that we can make about this session. I think the most important one that you made is that although we've had some proof of principle that transplant can improve outcomes and early transplant can be better than delayed transplant so far, we're still looking to further improve upon this. What can we do before the transplant? What can we do with the melphalan that we give? And what can we do afterwards to make it better in addition to maintenance? We think that melphalan, the drug itself, is still a great drug for transplant, and thankfully we've been able to make it more stable and more accessible to patients. But the transplant phase itself might be this ideal time to implement these new immunotherapies. As you mentioned, when the cells are growing and being re-educated, can we push them towards fighting against their own myeloma?
Ultimately, myeloma being a disease of your own immune system's inability to recognize the growing myeloma too.
And it's exhausted.
It's exhausted, and that if we reset that, we might be achieving a balance where the immune system might keep it in check.
Right.
And then, I think we should have a couple of cases just to demonstrate, what we discussed.
Sure.
So let me ask you a question. I saw this patient probably 4 years ago who was a gentleman who worked in a hospital, and he's a runner, and he gets his annual physical, and he was about to retire and enjoy life in the Upper Peninsula of Michigan, which is like a idyllic setting. And so he got his retirement physical, and they noticed a high total protein of about 10, with that albumin was about 3.8. And one thing led to the other, and before long he was seeing us with a paraprotein, IgG kappa of about 3 grams per deciliter. So we did a bone marrow biopsy, and his bone marrow showed 35% plasma cells, which were kappa light chain restricted as expected, but did carry the high risk marker translocation chromosomes 4 and 14, in addition to some other standard risk markers. And he had an extensive search, including a bone survey and a CT, whole body CT scan, none of which showed any bone lesions. His complete blood count was normal with a CBC, with no anemia. Creatinine was normal, calcium levels were normal. So, at that point, what would you tell this patient?
Yeah, this is a clear case of smoldering myeloma, right? So myeloma that is there but may not be clinically significant, like we don't have any indicators that organ has been damaged. And what we used to do with these people is wait until something did happen. Thankfully now we have a little bit more to guide us, and I think in this situation we could use those 3 options. So one, perhaps performing a whole body MRI if that wasn't already done, because we know that having 2 or more lesions that you may not see on a survey, but you can see on an MRI,
absolutely,
would push you to treat the patient. I think bone marrows can be interesting in these patients because it's important for these question mark cases to do probably 2, bilateral or sequential one very early on, because if the patient has more than 60% involvement, then you would want to treat them according to the new guidelines. And finally, looking at the light chains, because the ratio is important. And if it's more than 100, then you can make a case to treat them, albeit they don't have clinically significant disease. And in this case, very interesting, because they had a 414, right?
Exactly, yeah.
That's always concerning, and I think probably in that case, it's good to remember how many percentage of the cells had that, and think about how important this is for their disease. And I think, although they didn't make criteria to be treated, very close follow-up, closer than you might otherwise do.
Absolutely, because of the high-risk marker and as you very rightly pointed out, a high light chain ratio. He actually did not meet 100, more than 100, and at this time, this was, we didn't have these guidelines when he first met us. He was about 90 with this light chain ratio, but almost there. So it's always a question. This is a biologic distinction or an arbitrary distinction meant to treat. And the patient himself was not willing to get treated at that point because he was just about to retire and all that. But unfortunately, within 2 years, he actually progressed to active myeloma.
Right, which you would have predicted almost.
Which we could have almost predicted. Yeah. He was at the high risk end of smoldering myeloma. And importantly, now we have clinical trials for patients in this setting.
Yes.
So this patient actually went on to have active myeloma within 2 years, and then received upfront bortezomib, cyclophosphamide, dexamethasone regimen, followed by an autologous transplant. And then he chose to receive bortezomib maintenance, mainly because when we discussed the data of for 414 myeloma and the use of immunomodulatory agents versus proteasome inhibitors in that setting, he liked the data about the proteasome inhibition, and he went ahead and had a proteasome inhibitor maintenance. So he received bortezomib maintenance for a year and then stopped it, and then was followed for another 2 years. So a total of 3 years after the transplant, he actually relapsed with the rising paraprotein now. And again, no symptoms. It's almost all as if the smoldering myeloma came back. And after following for a couple of times with the paraprotein going up, we recommended treatment. And again, I offered him, by this time, more new drugs had come on the market, including carfilzomib. He had not seen lenalidomide so far, and he had not seen daratumumab, which was also available at that point. So at this point, he chose to use the carfilzomib lenalidomide combination, and he's actually had a complete response to that.
It's very effective, right?
It's very effective, and based on the ASPIRE study. And at this point, we are negotiating whether we should do a second transplant with his stored cells. And again, he had a 3-year benefit from the first transplant.
So he makes the grade, because even retrospective data, 36 months was even better.
For a benefit from a second salvage autologous transplant. So I think again, this, at relapse, he was essentially not refractory to any of the drugs, and he had already gotten about 3.5 years from his diagnosis to relapse, and that's very important. We have patients who relapse now who are not refractory to anything because he had stopped bortezomib 2 years
just
before.
on observation.
And just on observation. So it was, and again, it indicates to us the choices that we have for patients. So this patient hopefully will go on to have a second autologous transplant, and then he's planning on lenalidomide maintenance at that point.
Right, now he can do that.
And
Do you want to talk about a person on dialysis, maybe?
Yes, yeah.
Because I actually recently had this patient who had slightly difficult to control myeloma, but ultimately got cyclophosphamide and bortezomib dexamethasone. Unfortunately, when the patient had presented, he had light chain disease and had severe renal impairment to the point where he ended up being on hemodialysis. Even though he was given treatment with chemotherapy, his renal impairment did not reverse, and he was still on dialysis when I saw him for transplant consultation. And as we talked about, patients with renal insufficiency and even dialysis should not be not considered for transplant.
Absolutely,
they can be considered. And what we liked about his case was that he wanted to have something where he might have a longer-term outcome, and he had the support, and he was very interested in pursuing this, and his doctor was interested also. So he came to us relatively early in his course. So we evaluated him, and I wanted to get your idea. Would you have also considered him for a transplant with a good performance status, et cetera, otherwise?
I think dialysis by itself should not be a contraindication for autologous stem cell transplant. We know that it's a limited time event. Unlike an allogeneic stem cell transplant, there are no immune suppressive drugs. And dialysis, being a hemodialysis, is an effective intervention for these patients as a renal replacement. It can be done effectively in the hospital.
Right.
None of these patients are getting transplanted as an outpatient, obviously.
No.
They all have to be admitted to the hospital. They do have a higher risk of mucositis.
Right.
But most programs reduce the amount of melphalan we give them because it's a mucositis-inducing drug. And many programs do 140. Some programs actually ratchet it up a little bit more to 160 to 180 because of the dose-response curve of melphalan that we talked about. And I'm hoping for an era where we'll be doing melphalan with pharmacokinetics, where we actually can measure the amount of melphalan in the person's body and how it's cleared, and then we know how much we gave to these patients. But for the time being, we just completed a CIV-MTR study that was presented at ASH in 2016, where there was no mortality essentially for people with even severe or on dialysis undergoing transplant, and there was a significant proportion of patients who could come off of dialysis after transplant. So I think deeper remissions and an early transplant probably can get even more patients off of dialysis. If you achieve a complete light chain remission, his kidney might actually still have some scope of improvement.
Over time, right?
Over time, yes. We really should not use dialysis as a contraindication.
Right.
And the benefits accrue. In the setting of myeloma, hemodialysis turns out to be a risk factor because of the difficulty in giving certain therapies and the lack of efficacy. For example, you don't know the dose that gets cleared.
Right.
So I think we've had a really good discussion here, and the key takeaways, as we mentioned, are the importance of transplant even in the era of drugs, the importance of maintenance after transplantation, and also the referral to transplant being a key step in any newly diagnosed person with myeloma of a transplantable age and comorbidity status.
Right, and everybody deserves an evaluation.
Everybody deserves an evaluation. I think that's one of the biggest things that you can offer a patient who's newly diagnosed with myeloma, a transplant evaluation.
Great, completely agree.
Thank you for your participation in this CME activity. We enjoyed talking to you.